on CTO tool setup and hardware. We move on to session number 3, that's on antegrade, as we thank the chairpersons of the last session. We have 5 speakers for this session. Each of them would be given 12 minutes, 10 minutes for presentation and 2 minutes for discussion. To help you be on time, we have a diagonal timer on the left-hand side of the hall, top above. With these few words, I'd like to invite Professor Vijay Kumar Trehan, Director Professor of Cardiology at Gobind Banda Pant Institute of Postgraduate Medical Education and Research, New Delhi. He is joined by Professor Gerald S. Werner, Director, Department of Cardiology and Intensive Care at the Darmstadt Clinic, University of Frankfurt, Frankfurt, Germany. I'd request the chairpersons to please take over by inviting our first speaker onto the proceeding. Over to you, gentlemen. Thank you very much. In the meanwhile, requesting all speakers of succeeding sessions to please load the presentations and kindly be ready for your respective call. Over to the chairpersons, Professors Trehan and Werner. Over to you, gentlemen. Thank you very much.
So I think we'll be discussing the most important and the traditional antegrade technique, and I think we start with Colonel Dhall, who will be talking about step by step.
It's great to be here at ijcto, and I must compliment Professor Goel and his team for a wonderful meeting. Most of the topic has already been covered, and I can actually conclude by saying that everything about CTO is known to most of the people here, but nothing about CTO is known to anybody in particular. So, hey, the slides don't change. I had changed the slides. No, I changed the set. Sorry, I had actually... He showed me that it has all changed. So anyway, we all know that choosing a wire... Can you find the others? So choosing a wire is the first step after getting a good access, a bilateral access, understanding the CTO, understanding what we are going to do. We have to, and making sure that we have a good control angiogram. We have to now understand if we are going antegrade, are we going to do an antegrade wire escalation? Are we planning to do an antegrade dissection re-entry? Or are we planning to go retrograde? Now, most of the time, the beginning is always an antegrade, and traditionally, till the 2000s, we knew, early 2000, we knew that there were 2 sets of wires and 2 penetrative and techniques which we used. Have you got it now? It's not fair. What happened? I told him to delete the other set. No? No, this is, I can, yeah. Okay, apologies.
In case...
no, it's okay. It's, I think it's
that's fine.
Just a little, yeah. Because when you have a topic, you don't know the topics before and after. So it's only when you come to a meeting you realize that most of the talk that you're going to give has already been covered by other speakers. So I actually happened to change some of the slides. Are we okay? Yeah, no, it's good. So I'm sorry for that beginning. And like I said, we need to identify, once we have decided that we are going to go antegrade, we obviously look at many things which Praveen Goyal actually taught us, as to see the proximal cap, see what is the age of the CTO, see the length of the CTO, and all this helps us choose, because we have to understand that there is going to be vessel heterogeneity, there is going to be some portion which is going to be fibrotic, some portion which is going to be calcified, and there is a significant influence of pathological heterogeneity even in short lesions, but which increases dramatically when you actually have a longer lesion. So this is reflected in decreasing effectiveness of antegrade wire escalation in complex anatomy, as the final strategy may change as per rising JCTO score. And this may need to alternate strategies, especially if there is some tortuosity and calcification along the length of the CTO. So coming back, we had two sets of wires, a wire which was more hydrophilic like the Conquest family, and a wire which was more controllable like the Miracle family, which gave us a little tactile feel. And this is how we started doing our CTO interventions. But we always had a difficulty in re-entering the true lumen from the subintimal space if we went subintimal. And for this, to overcome this, we had the parallel wire technique, which was always taken by a sharper bend, a heavier or a stronger wire, which had a more penetration force, which was taken so as to allow us to enter from the parallel wire. We also learned a very elegant presentation on CTO pathology, that from 40 to 400 microns, we have some kind of microchannels. It is still sub judice what these microchannels are, but we also realized that to enter these microchannels, we need small tips. And so therefore, these small tips not only help us enter the microchannels, they also help us by increasing the tip load, because the penetration force then increases. And all this changed with the presence of the Fielder XT, which was a tapered, flexible, hydrophilic wire with a slip coat, which was very effective despite the low tip weight. And this is, unfortunately, there was poor torque transmission and handling in the CTO body with low penetration and a weak tip. Secondly, there was a kind of a whip motion response whenever we would use any of these wires. And to overcome this, we had the rope coil, which was introduced in both the XTA and the XTR, which again became a kind of a default strategy. So if we look at a case, I'm sorry, this is all working there. So anyway, so we look at a case wherein we thought there were microchannels. We could use a Fielder XTR, which was our starting wire. What are you doing? This is going crazy. And that could achieve recanalization. Sometimes when we needed to create a blunt microdissection, and this is not popular with our Japanese counterparts or even in India, but the Americans and the North Americans actually showed us that we could go around the total occlusion, especially if there was calcific nature, and create a knuckle by creating a blunt dissection and thereafter creating a re-entry. And to help us achieve all this, we had the Gaia wire, which have been so elegantly described, which is a composite core wire, which actually helped us achieve active wire control by either deflection or direction control. And all this we have actually been through. And it helped us use even a softer tip guide a guide wire to have a better result. And by deflection, we could actually cross the segment. So here is a patient who actually has a LED stump CTO, which by careful manipulation, by taking a Gaia second as our primary wire, we could actually cross. And when we had to use the parallel wire technique, we could use a second wire, which is actually a Gaia third, and we could cross the lesion and get success. The advantage of the Gaia wire obviously was that we had balanced core flexibility, penetration efficacy, intentional control and response, and good shaping memory. So but sometimes, like it was explained by Dr. Goyal, these wires all of us who use Gaia wires have sacrificed Gaia wires, because especially when there has been calcification, these wires are like Abhimanyu. They can enter a lesion, but when you try to remove them, they actually break. And this especially happens if you use any amount of torque to get them into a lesion. So the best way to use them is just to deflect them, and there are now the X-strand coil which has come, which is a replacement over the Act 1 coil, may actually help us by having less amount, because the X-strand coil is actually a hollow coil which is now going to be used in the Gaia Next, which unfortunately we don't have. So if you are to choose a path, if you're going to do loose tissue tracking, we need a tapered tip, low tip load, lubricous wire. If you're going to use a hard cap for a tissue penetration, we need to do a tapered tip with high tip load, and can be followed by de-escalation, and occasionally you need a directional tracking. So for loose tissue tracking, we need the Fielder family. For hard tissue puncture, we need a Confianza, and for directional tracking, we need a Gaia. So the newer wires include the Ultimate Brothers wire, which is probably the new Miracle 3. We also have higher tip load wires like the Conquest Pro 820, which has a greater tip load and penetration force. We have the Gaia Next, which is now again a composite core guide wire, which has certain definite advantages over the Confianza and over the Gaia Third. We can compare these wires and use them appropriately as the circumstances arise. Because if you have a difficult entry with a tough tissue, you will have to decide whether to use a Gaia or to use a Conquest Pro to achieve a re-entry. But most of the time, we can see the distal lumen even by a contralateral injection. Then a directed penetration from an extraluminal plane to true lumen can be done with a Conquest Pro. Otherwise, a Gaia Third is what we are using today. Because we need to understand that the calculated penetration force is little different from the modified penetration force, and the modified penetration force with the microcone of the Gaia gives the Gaia a definite advantage. Again, the redirection can be used with either the Gaia Second, Third, or the Conquest, or it can be used by using the double lumen catheter or some of the other new wires that we are talking about include some peripheral wires like the ijcto, and some new wires which have come from Boston Scientific. There is a Sentai range of wires which are not freely available in India. I keep getting told by my Boston colleagues that they are going to give them to us for trials. Some of them are already being used, which have very similar characteristics, but we need to learn how to use them even better. And some of them have tapered tip, and the ijcto offers you greater penetration power. We have the ijcto 20 and 40. So if you take a Japanese algorithm, we would start with the Fielder XTR, go to a Gaia Second, and maybe a Confianza Pro. Whereas in the US, we would probably take a Fighter, Pilot 200, and Hornet 14, but we need to get used to our own basic algorithm, which we need to decide. And really, an XTR plus minus XTA. XTA is very little used. XTR, unfortunately, XTR doesn't have a great tip load. It has got only a 0.6 grams. And then we move on to usually a Gaia Second, and then to a Conquest Pro. In concept, we should think that initially we are doing a passive wire control, moving to an active wire control, and then for a calcified tissue penetration, we can use a Conquest. So this would be a series of wire escalation. There are some new wires. And like the shockwave technology is shocking calcified lesion, we are also have a shock wire which is going to be available, and this may actually change the soundbite CTO crossing device, may actually change the way we look at CTO interventions. But if we are going to do a quick recap, if you have to wire a tapered cap, a low tip load polymer jacketed wire, if you have to wire a blunt cap, a penetration wire, if you have to work within the loose tissue, within the CTO, you can de-escalate with a low or medium tip load polymer wire, or even a medium or to tip load high torque wire. And if you have to wire calcific segment, we can have either a re-escalation or use a penetration wire. So the choice of anatomy, the choice actually determines what we are going to use. If you have a tapered proximal kip, we would start with an XTR. If you can use the initial soft polymeric wire, and if as the complexity increases, we can actually use a medium weight polymer wire, or we can move to even a Gaia Second. If it is a blunt tip, if you can see the distal cap, if you can see the distal vessel very well, you can, and if it's short segment, you can use a Conquest. Otherwise, a Gaia Second is a good wire to start with. And if it's a completely blunt, it's calcific, you know the direction, you are confined to the architecture of the vessel, only then use a conquest, otherwise use a Gaia wire, because this is a wire which would need to be penetrative with a high tip load. Here is another case with a blunt proximal cap, increasing markers of complexity. A penetration wire was used, and then once the wire was directed through the body of the lesion, we actually de-escalated. And here is another case where we not just de-escalated, we actually had a re-escalation to get to the distal cap. And by re-escalation, here's a polymer wire which failed to penetrate the cap. We escalated and then placed the microcatheter, punctured the distal cap, and then we moved on from escalation to re-escalation to de-escalation, finally re-escalation to actually cross. So if you take a non-acute occlusion, identify the proximal cap, look at it, whether it is a recent or pseudo-occlusion, use a soft-jacketed wire. If it is a true CTO, no microchannel, do a directed penetration. If there is a microchannel, well, you can use a stiff-jacketed wire. So the wire strategy would be normally a Fielder XT, XTR, over to a Gaia second, over to a Conquest Pro, which would be the simplest. And then, if at all, we need to incorporate other methods, like a parallel wire method or an IVUS guided, and the SUO 03 and so on are actually very good for epicardial or for crossing collaterals. So all this can be incorporated in our wire escalation matrix. Thank you very much, and I apologize for the problem with the slides. We checked it outside, it appeared to be all right.
Thank you, Anil. I think in the interest of time, everything was clear except the fact that there are no microchannels in CTOs.